So right now, I assume the participants are joining.
So shall I begin?
We have already about 60 people participating. So I'll give one more minute to those who want to enter so that they have the time to do that. And afterwards, we will begin. Still have people joining, but I want to be on time. So with that, I will start this seminar, this symposium, and I'll pass the word to Ramazan. Ramazan Salman is the executive director of the Ethnomedicine Centrum. He'll give you the welcoming words. Ramazan, the floor is yours.
Thank you very much, Rui. Dear colleagues, dear participants, dear cooperation partners, dear supporters, dear speakers, good afternoon. I would like to welcome all of you to this European Symposium on strengthening capacities for better healthcare to refugees and migrant children. This symposium is the outcome of the work of several institutions working together for the years in the pursuit of the common goal to provide better healthcare for migrants and refugee children in Europe. This work took place within the framework on the European Vet Care project, and we will be using this symposium as an opportunity to present an overview of the project and its results. The project is an initiative of many partners and has received support from the Erasmus Plus program of the European Union. Therefore, I would like to thank the partners, Prolepsis, Paros, Zadig, Polybienestar, and Cyprus University of Technology. I would also like to thank the financial and administrative support of the European Union and the NABIB, which is the National Agency Education for Europe at the German Federal Institute for Vocational Education and Training. Finally, I would like to thank the team of the EMZ for conducting the project, in particular Daria Ryshova and Rui Maya. This project would not have been possible without the assistance of all these persons and institutions. Now I want to say a few words about us, the Ethnomedical Center. The EMZ is a non-profit health organization that brings together people from different professions, cultures, and traditions. As a national competence and reference center for migration, health, and integration, we provide language and cultural sensitive education, prevention, and counseling services. We also provide interpreting services and information materials. The EMZ also improves the transfer of knowledge between science and practice in the transcultural field of through research activities and conferences, such as this one. The EMZ is funded by the Lower Saxony Ministry for Health and the City of Hanover. The EMZ also receives project funding from the state government of Bavaria, Hamburg, and Schleswig-Holstein, the Federal Government Commissioner for Migration, Refugees, and Integration, the National Health Ministry, the European Union, and the Federal Institute for Vocational Education and Training. The EMZ has received several awards for future sustainability, quality, and prevention. The EMZ MIMI technology with migrants for migrants was recognized in a WHO case study in 2010 as a key technology for the integration of migrants in the health sector. For its commitment to the health of migrants in Europe, the EMZ received the European Health Award. We are therefore proud to contribute to the EU Vet Care project in general and this symposium in particular. We learned a lot during the project, and we are glad to share what we learned with you today. We hope that you will find the symposium relevant, engaging, and inspiring. So it's a pleasure to me to invite Rui Maya for moderating the conference in the following. Thank you very much.
Thank you, Ramazan. Thank you, participants. Now I'm going to say a few words about our agenda today. So after these very nice introductory words from Ramazan Salman, our executive director, we will have two sections of this symposium. In the first section, we will focus on general topics regarding the health situation and needs of migrant and refugee children. We will be able to hear from experts in the area and see what contributions that they have to make, that they have available for with respect to this topic. And then afterwards, we are going to introduce our project and give a very brief overview of the situation of migrant and refugee children in the partner countries of the project. So that's the first part, the first section of the symposium. Afterwards, we will have a very short break of 15 minutes at 15:15, and then we will start with the second part. And the second part is going to be where we are going to focus on the project itself, on the project research findings, on the modules that we developed, on the e-learning platform that we developed, and also on the other outputs of the project, in particular the training guidance and recommendations that we also developed. In the end, we will also have some time for questions and discussions that you may have to this seminar. Now, without further ado, I would like to pass on the word to our next speaker. Our next speaker is Professor Dr. Benedict Kumar. Professor Dr. Benedict Kumar is associated with the Norwegian Institute of Public Health. She is chair of the Global Society on Migration, Ethnicity, Race, and Health. She's co-chair of Lancet Migration, and she's president of the European Public Health Association, Section for Migration and Ethnic Minority Health. It is my pleasure to give the word, to give the floor to Professor Benedict Kumar. Please, Professor, the floor is yours.
Thank you so much. At the outset, I'd like to thank the organizers for this invitation to speak, and I'd also like to thank Rui for giving me the opportunity. And to the rest of you, I would say fasten your seatbelts because I have a lot to cover in 10 minutes. So I will try to be quick, and I hope that you will get my slides at a later date. Don't catch everything I'm saying, you'll be able to get the slides later on. So migration is a very vast topic, and I'm going to cover some general aspects of it. And then I think Professor Hadjo is going to go a little bit more in depth in terms of looking at the challenges for children. And what I'm going to do in this brief 10 minutes after introducing the topic is to talk about who, what, why, some key concerns and the way forward. First of all, mobility. When we talk about migrants, it's about 1 billion people on the move. And then you might say to me, but that's a lot of people. We've never heard that figure. Because a lot of migration actually happens within the borders. And we focus on the 258 million international migrants. But regardless of whether they're international migrants or they're people moving within the country, the migration experience sets people aside, and often they become disadvantaged because they face inequalities, inequity to healthcare, and also in addition, particularly with the international migration, face racism, microaggressions, and structural inequities. And when we talk about migrants, we talk about really heterogeneous groups. There are economic migrants, regular migrants, irregular migrants, trafficked persons, ethnic minorities, asylum seekers, and refugees. So often we're talking about a very large group of people, and we put them all together in one category, but actually they are very different. And today's topic is a very important topic because it also is the intersection of two areas of concern globally. Migrant health I've already talked about, and child health is a very important area because in all countries, children, particularly those under the age of 18, are of utmost importance to societies. And we know that every year, almost 6.2 million children under 15 around the globe die. 1 in 13 of those children are in sub-Saharan Africa. And we know that a lot of the migrants from sub-Saharan Africa do come to Europe. We also know that the major causes of death among children is infectious disease, and these account for most of the deaths globally, but also injuries and accidents. So when we look at global migration and children, we see that of the international, 30 million were children. When we talk about migrants, there's a lot of focus on adults, but very often the children are not focused on explicitly. It's often implicit when we talk about families. But as you can see in the case of refugees, nearly 50% of all refugees are children. And among the 40 million internally displaced due to conflict or violence, 17 million were children. So often children go by not very much noticed, and migration offers both risk and also opportunities for children. Post-displacement, labor migration, and rural-urban migration are the main trends affecting children. We also see that migration patterns and pathways are very complex. So you need a life cycle approach, you need epigenetics, but because also migration nor health is static. So understanding these complexities is very important for us in order to find out how we should address them, and how we should address them then leads into how we should strengthen capacities to do so. And the first thing we need to do is always dispel the migrant health myths, identify what are the challenges and what needs to be done. What I would like to say here, which is very important, besides the policy coordination, is for the longest time, particularly in Europe, we're in need for a paradigm shift. We're in need for investment in migrant health because it is an investment in the future. Migrants should be seen as a resource and not just a burden. And we know that with the SDGs and the focus on universal health coverage cannot be realized until refugees and migrants are included. And finally, with COVID-19, we know that it is not an option to leave anybody behind. So I'm going to present 4 very quick arguments as to why we should bother about migrant health. The first is the rights argument, and everybody knows about the right to health and why healthcare is really a human right. We also have the rights of the child, and the Article 14 in the Convention of the Rights of the Child states very clearly every child's right to good health and possible health, etc. And I don't have the time to go into details about the rights of the child at the moment, but both the right to health and the rights of the child ensure that children must be a priority when it comes to health. We also have the economic arguments, and for the longest time, migrants were always thought about as being a burden on the healthcare system, and that is not really true. Our Lancet Commission did show that they are not a burden on high-income countries, as was thought. But if you look at this double helix, we know that health is often associated with countries or where there's resources, and poverty often leads to ill health, and it's a vicious cycle. So that's the economic argument as to why we should bother about migrant health. The crisis argument is what we're used to. Here is the crisis from 2015-16, when we saw a lot of refugees crossing the Mediterranean. These are the migrant workers in India during the COVID crisis, having to walk back long distances. And what we know about crisis, whether it's man-made or natural, is that the migrants and the refugees will keep trying until they succeed or die. And therefore, it's very important to take care of that. There's also the anti-discrimination argument, and the anti-discrimination argument is that there is a lot of hate campaigns, mudslinging against migrants, scaremongering, deliberate misinformation, outright lies. And this also leads to problems within societies, within countries, within communities where migrants and ethnic minorities do get marginalized and do have to face racism and xenophobia. And that's why it's really important to address it fairly early. The last argument, and I would say the most important argument, in case you haven't bought any of my previous arguments, is the humane argument. And this photograph of this little boy, I think everybody knows. And the most important thing in this particular picture and the argument that I'm presenting in the Humane Argument is that migrants are not a faceless, nameless group. Everybody has a name, everybody is an individual, and everybody is somebody's child, father, mother, etc. And as it was said, that this boy has his name is Aylan Kurdi. So I hope that you have bought some of these arguments, and from some of the arguments as to why we should bother about migrant health, let's move on very quickly to what we know. And in the past 20 years or 2 decades or so, there's been a lot of literature that has been produced. But if you look at this analysis, which is done here, you'll see that there are not so many studies on child health. Child abuse, yes. Violence against children, yes. But those are the only studies that we find in this bibliometric analysis. So there is room for having more research and generating more knowledge about the health of migrant children and refugee children. UNICEF has also produced a lot of good research, and it is forthcoming, and the Center in Innocenti has a lot of research. But I think that what is important is the research has to be done not only at the global level or regional level, but also has to be at the national and local level. So it is relevant for those who need to use the research. And then if we look at health inequalities, because migrant health is really part also of the larger health inequalities. And if we look and see what has happened in terms of health inequalities, we see that EU projects are tackling health inequalities in 2003, 2009, were looking really at data and analysis, whereas now it's really moving from that to looking at policies and policies within and policy research is very important to tell us where the gaps are and to identify how these gaps can be filled. Sorry. And if you look at this particular slide, and this is the EU review of 2013, again, looking at inequalities, it was really ranged into three types of groups. And you can see that you have groups where it's red, and those groups were advised when it comes to inequalities in health, do some. And then you had the group, sorry, the green color, the red color is do some. And those who had already started working on actually evening out the inequalities, it was do more. And for the groups that that had already addressed some of them, and you can see those countries there, it was do better. So, so as you can see that we have, sorry, this is not working. Yeah. So that was in general when it looks at when you look at inequalities and look at policies. So addressing the needs of children on the move is also very critical, because children have specific support needs that change during the trajectory, because two things are happening to them. One is migration, which is in itself a very complicated process, and the other is childhood, the transition from childhood to adolescence to adulthood. So all these things are happening at the same time. So besides the basic rights like housing, food, water, education, shelter, you also need emotional and psychosocial support. And also the challenges that they encounter when managing relationship, coping with violence, dealing with their own transitions, as I mentioned, into adolescence and adulthood. There are three particular challenges that I would like to share. One is that access to children when it comes to healthcare, particularly in the European context, is also tied to entitlements and benefits, and therefore assessment of age becomes very important, because if you're a child, you do get some benefits, and if you're not a child, you don't. And however, we know that these measurements and the assessment of age is very flawed. So this is a very big challenge, and therefore an area that really needs to be addressed. The second area, which is a special challenge, is guardianship and protection. Children deprived of parental care, having lost parents, and we've seen this has also happened in the COVID pandemic, child trafficking, abuse, and violence. And then you can look at the violence towards children cases for court. And what's interesting from this data from Norway, you'll see that there were 15 cases of families of Pakistani origin, 7 in Norway, and actually some migrant groups had less than the ethnic Norwegian group. So it also goes to show that not everything is, as we think, all dark and all gloomy with migrant population. The issue of girls, and again, because of the transition, because of trafficking, early marriage, motherhood, teenage pregnancy, All these issues are also very important special challenges for children, particularly the girl child, and therefore this is also something that needs to be focused on. Since we cannot forget COVID, and we don't forget COVID, I'm just going to spend 2 minutes on COVID, though I do not have the time to go into detail. What COVID has done is it's an exacerbation of pre-existing structural factors in the migration context. There's an interaction of multiple factors which make migrants and ethnic minority groups at higher risk for COVID-19 infection and higher morbidity and mortality that we have documented. So there are 3 levels that this is happening. There's the pandemic and the economic impact that exacerbate both within the health system, large gaps, and particularly we've seen migrant and migrant families who are really at high risk. And the existing inequalities, again, poor and crowded living conditions for migrants. And we see that that's a problem. And there are political factors, such as I've already mentioned, that also are disadvantages for migrant and ethnic minority groups. So the way forward for COVID and managing COVID is really looking at more data and research, looking at areas of governance and policy. And this is also not very different from what we need to do in migrant and ethnic minority health in general, but COVID has just given us the push and saying why this becomes even more important. And I always say that equity is actually the best practice to include as many people as possible and not to exclude them. The Migration Integration Policy Index, some of you might be familiar with, and it really covers policy areas for migrants in more than 30 countries, and particularly in Europe, we've used it a lot. And if you look at that, you will see the countries in Europe and out of Europe into 4 real areas where you have good access but poor quality of healthcare, where you have both good access and good quality, and you'll see a lot of countries here, and you have poor access and poor quality, and poor access and good quality. And of course, we need to work in particular in these particular areas where we found these policy gaps. What can be done? There are a lot of European, both WHO and EU initiatives, such as guardianship system for children deprived of parental care. There's a global plan of action for health systems addressing violence against women and girls, etc., etc. So what we know is that the urgent challenge, and this is something that this particular project does, is to really take some of the knowledge that we have and change it into practice. And I think building the capacities was that. It's important to tackle both socioeconomic inequalities and those links to migrant and ethnic minority background. And very important, I think we often end up tackling things within the health system, but we forget that we are also connected to outside of the health system. I think here also you have tried to make an attempt to do that. So tackling both upstream measures and downstream measures. So we need to promote and protect health. We need to learn more, and we need to take action. And I would like to congratulate everybody on this project, because I think that you have managed to do all of that. Finally, I leave you with Martin Luther King, who says, all forms of inequality, injustice in healthcare is the most shocking and inhumane. And of course, Gandhi, who says, you have to be the change that you want to see in this world. And I think that your project is one step to that. So thank you very much for this opportunity. And once again, congratulations. And I look forward to hearing your results.
Thank you very much, Professor Dr. Benedict Kumar. You've given us a very good overview of the complexities of migration, especially the needs of the children on the move. And you also made a very convincing case for caring about migrant and refugee health in general, and especially migrant and refugee children health in general. Thank you. And with that, I would like to move to our next topic on the agenda, which is our talk by Professor Dr. Hayut Tzir. Professor Dr. Hayut Tzir is the chair of the Department of Prevention and Evaluation at the Leibniz Institute for Prevention Research and Epidemiology. And today he's going to give us an overview of the challenges of health and healthcare of migrant and refugee children. Professor Dr. Hayut Tzir, the floor is yours.
Thank you very much indeed, and thanks for inviting me also. And I have a very easy job because Bernadette, I was quite sure she will cover a lot of those issues that are really relevant to set the scene, to provide a frame and to show really the many influences. And I also knew that she's going to do a full roundup. So I actually only have a few slides, which may sort of perhaps also instigate some discussion and joint thinking about where we stand. So I'm looking at, some of these challenges, and indeed Benedict already mentioned particular challenges, and I've got a few more. And I think in principle, it's actually a task that we can only tackle with an overview, because individually there's so many challenges that actually come up when you practice healthcare of migrant and refugee children, that you will probably encounter everyday new challenges as you go along. But let's have a quick look. I think if you look from the health of children's side, you will realize children have particular health needs. They also have particular health patterns. We heard about infectious disease, for example, particularly affecting children, diarrhea, but there are also many other diseases that one may need to take care of. And Bernadette also mentioned the mental health and the psychological needs that are definitely there. On the other hand, you will also realize that children do have particular health threats and vulnerabilities. This is not true for all children. They just simply cannot take so well care of themselves as adults are supposed to be able to do. But especially refugee and migrant children, they are in a terrible situation, and they really have issues that often will be quite difficult to, even with good support, live through. On the other hand, we need to also realize children have particular resources. They heal quickly for certain diseases. They are really fantastic sometimes in the way they can cope with issues. They have also something that we call resilience. And again, this is a kind of a property or a capacity that they can develop, and that can actually lead them to good outcomes, even under difficult, stressful situations. If we look at in the childhood overall, I mean, obviously, in terms of a life course view, we know childhood is a very important phase, and that makes it even more important to realize that migrant and refugee children, if they're supposed to, fulfill their full potential, as Bernadette also said, I mean, they are a resource also for countries that they join. Childhood can really set the scene for adult health, adult disease. And very importantly, we need to realize as you are a child, you are dependent on your family, your parents, your siblings, and they may also, for the healthcare, then be the entry to proper or less appropriate healthcare. Surely there's high potential for traumatic experiences during migration, and we heard that already. There's separation, and the unaccompanied status is particularly relevant, I think, for the healthcare and social system as well, because that really sets the scene for major problems in the countries. The social systems have to cope with this situation. The children are particularly under threat for all kinds of developments. And if we look at the care side of things, it is often sketchy. Maybe it is not continuous, especially along if you look at refugee children in particular, it's definitely interrupted. They may have some healthcare in some situation, then no healthcare in the next situation. Sometimes there is actually no healthcare at all in conflict zones or during flight. So this may be particularly difficult. So this makes it even more important that the destination country offers, whatever is possible. But there are issues, and we'll come to this in a moment again, in terms of access. Language issues often may, play a particular role. We have lack of specialized services, and also a lack of, let's say, preparation in terms of knowledge in the routine services about the particular needs and problems that a refugee migrant children may encounter. We heard about the right to health on the other side. So children, they are definitely particular in the sense that they enjoy all the rights that adults should have, and really need this extra bit of protection and support to attain those rights. And in Article 24, I mean, we don't want to go through all the articles, but if you look at the Convention on the Rights of Children, it just clearly also states they have the right to enjoy the highest attainable standard of health, and that is a major guiding rod and pillar, I think, also for the organization of health and healthcare for children. So if you take this aim, if I come from a healthcare point of view, and my aim is to provide the highest attainable standard of care to all children, what do I need to do as a healthcare provider? I will need to take note of the particular vulnerabilities, of the requirements, of the social situation, and also of potential, for example, disabilities and special needs. We should not forget that even in the refugee and the migrant population, and maybe particularly so, there are very different resources also. They may have also very different socioeconomic background. They have maybe different family resources. Some actually come from rich families, some from poor families, some from large and small families. So this differentiation is needed. We have the diversity in terms of language, the norms and values, cultural issues may come around. So there are multiple challenges, and I don't want to go into all these challenges, but I've just written down, and before actually looking at what the project does, I've really looked into my own thinking in this and a little bit into the literature, what I see as major challenges. And this is challenge number one would be for me that you actually need to have awareness and readiness of the health system and the healthcare workers. And some possible answers might be, first of all, take stock of the services. What do we have? Then provide information on particular situation and needs, and then develop and perform training for those identified gaps and the situations that need to be taken care of. So that would be towards the challenge number one. The challenge number two is perhaps limited access again. So limited access to the healthcare system. Again, it means we will need to take stock. What are the access issues? We need to identify barriers, and we need to provide low barrier, ideally no barrier access, and also low cost access to those services that need to be there. Another challenge, I think, that is perhaps a little bit then towards geared towards the population that we're looking at, is that there may be also very limited trust in the healthcare system on the side of the migrant and refugee group, because I mean, they have gone through lots of experience. Also the children, they may be very wary of adults, trying to help them with whatever, and they don't necessarily realize this, that this is a beneficial development that they're now going into. So possible answers here will be that you need to work with a particular refugee and migrant community. You need probably facilitators, trusted persons from the community, ideally. You will need to develop appropriate communication information. And I think it's very necessary to be respectful, to provide respect, and to have respect for the groups, the children, the youths and their needs. But one thing that we shouldn't discuss, you also need to actually provide high quality service, because if you provide low quality service, this trust issue will not go away. And this is one experience that I have from my own work many years ago in Namibia, that I mean, you need to really also aim for best quality service, because people will measure you also for what kind of service you are providing. So this is important also for generating trust and have a trustworthy relationship. I said already, there are many further challenges, and I think some of them may be the provision of integrated healthcare, not have separated services. You will also need to look at overall education, not only for health, but in the general sense, because education is, as we know, for these children, for youths, the prime way to actually do something for their own health in the future. So education will be a cornerstone of good health in the future. And very importantly, also caring for mental health of children and families beyond, physical harm that may have occurred in the processes. You will definitely face a lot of mental health issues that need to be appropriately treated and taken care of. And there are many more, I said already, so I've just identified a few, and I would be interested to hear from the project now that I think is very useful to tackle on a joint European scale, because there's a lot of joint experience that is out there, joint problems faced, and so it is a very useful thing to tackle this or to work towards, joint European approaches. So I'm quite happy that this project came along and did this. In a long-term view, I just want to mention that children may face, or may be part, in fact, important part of the epidemiological transition that they are going through. I myself, I'm an epidemiologist, so from the threats that they may have encountered elsewhere, now they may encounter new health threats. I just mentioned here, obesity, low physical activity, smoking, exposure to excess social media, whatever. So these things that we know from the children living in the industrialized countries that face major problems now, will these things also occur then for refugee and migrant populations, and especially for children as well? So we need to integrate this kind of long-term vision also into our approach to high-quality healthcare provision for children. And this is an important task that needs to be taken on, I think, from day one, really, ideally. Okay, so I was not going to say much more. I think this is what I wanted to relay to you and discuss with you. And thanks again, Benedict, for a wonderful introduction. And I hope some of these thoughts may be helpful to discuss further on. Thank you very much.
Thank you very much, Professor Hayutzi. It was really nice to hear you talk about what we have to keep in mind when tackling the challenges relating to empowering health services so that it can deal better with migrant and refugee children. And with this background, I would like to move now to, well, introducing our project so that you can have a better idea of what we are doing to tackle all the challenges that have been mentioned both in the talk by Professor Zieb and in the talk by Professor Kumar. So let me begin. I hope you can see my screen. So what is it that we do? I'll say a few words about our project. I'm going to say, well, why do we need such a project? I'm going to be quick here because we've been fortunate enough to have two amazing people make this case for us. Then I'm going to say a few words about the aims and objectives of our project, the target group of our project, and who we are, so that you know who's been behind this symposium today. So why do we need such a project, right? So this is no surprise, but since 2015, Europe has experienced increased migration and refugee flows, and this is so in most countries of Europe. The COVID situation has sort of reversed this trend a little bit, but Europe is still receives a large number of immigrants. And what is important about this is that 1 in 3 immigrants is a child. It's of course this number changes, but over time it seems that about 1/3 of all migrants and refugees that come to Europe are children. And of course, the arrival of these people provides challenges to health services around Europe. And this is something that, for instance, Professor Zieb has made clear in his talk. So I'm not going to say much more about this. Now, there are many problems in providing healthcare for these particular demographic, but one big problem is that healthcare professionals are not sufficiently trained to provide healthcare for them. Surveys show that this lack of training is particularly acute with respect to children. That is, migrant and especially migrant children have health needs that which cannot be dealt with, or at least not in an easy way, by professionals who have been trained usually in the usual way that they are trained here in Europe. So what is it that we want to do? We want to we aim to implement and design innovative vocational training on the appropriate delivery of healthcare for the situation. So that's what we want to do. We want to improve the situation. Now, more specifically, what are our aims? So we aim to enhance professional capacity to respond to the needs and health and specific health social issues that most affect migrant and refugee children. This is something that Professor Zieb has made an effort to press on. We also aim to enhance the partners' capability so as to develop and deliver training to professionals working with migrant and refugee children. That is, we want to make sure that professionals working with this demographic are properly capable of doing the jobs and know what awaits them and what issues, what challenges they have to face. We also want to increase the awareness of relevant professional communities and organizations during the training. That is, we want to make sure that they understand and they are aware that these particular community need particular training in order to be taken care of properly. And we also want to raise awareness of the necessity of the interdisciplinary collaboration among professionals, because very often there are cultural and linguistic barriers which require that professionals work together, and very often they're not trained to do so. So they're not trained to work with the cultural mediators, or they are not trained to work with the translator. And it's important that they be trained to do so. Now, what are our target groups? Well, we want to target professionals working with migrant and refugee children, but more specifically, physicians, psychologists, social workers, cultural mediators, interpreters, and other relevant aid workers. Now, I'm going to say a few words about who we are. And since we are running a bit late, and our executive director, Hamad Salman, has said a few words about us, I'm going to just mention here that we here at the Ethnomedical Center, the Ethnomedical Center, are the project coordinator. But we have a consortium of 5 additional organizations which are located in 4 different countries. And with that, I would like to invite the partners to introduce their own organization. So please, the partners from TATIC, would you introduce yourself and what you do?
Hello, thank you, Rawi. Hello to everybody. I'm Eva Benelli, project manager for Zadig. So we are a private media company, a scientific editorial agency, and we are specialized in communication and training on the topics of medicine, public health, and science in general. And Zadig makes its expertise available to local, national, and international authorities in 4 main areas: communication, publishing, e-learning, and research. Developing and realizing projects of communication and dissemination. Zadig has been also on the forefront in Italy in developing independent distance training activities for healthcare professionals, and not so only healthcare, in the frame of the continuing medical education. We developed the e-learning platforms, but above all, an adult education model leading the way in terms of content quality. Thank you.
Thank you, Eva. Thank you for presenting Zadig to us. And now I want to move to Prolepsis, our Greek partners, one of our Greek partners. So please, would you be kind to introduce yourself?
Hello, Rui, thank you. Thank you very much. I'm Pania Karnaki. I am the Director of European Projects at Prolepsis Institute. Very happy to be here. A few words about Prolepsis Institute. Prolepsis Institute is the Institute of Preventive Medicine, Environmental and Occupational Health. We are a non-governmental organization, a research organization active in the field of medical research, health promotion, environmental and occupational health. Prolepsis was founded in 1990 by Professor of Epidemiology Athina Linos of the University of Athens. So we are celebrating more than 30 years of active involvement in public health issues, both in Greece and Europe-wide. We strongly support the belief that health is a fundamental, non-negotiable and inalienable right for every human being. Work on 3 sectors. We work on research, we work on education, developing and implementing training for various professional groups, and we implement large-scale projects on various issues of public health and for various population groups, focusing mainly on vulnerable groups like migrants and refugees, and working very hard for the alleviation of health inequalities, both at European and at national level. So that's very briefly who we are, and thank you very much, Rui.
Thank you, Pania. Thank you for introducing Prolepsis. to us. And now I'm going to move to our second great partners, that is FARers. Would you please be kind enough to introduce yourselves to our audience?
Yes, hello to everybody. I'm Kenneth Hansen from Faros, also situated in Greece. We are an organization, NGO, working directly with migrant children and unaccompanied minors. As you can see, our motto is lighting their way, and this is what we try to do. We try to individually assist each of the children that we are working with to find a durable solution for them to either stay in Greece or find to return to their country, or to find their family in another European country. And we do that by working in three ways. First of all, we have street work where we work in the streets of Athens, trying to locate and find, unfortunately, some of the many unaccompanied minors who are homeless, and try to identify them and try to provide them with immediate assistance, finding them shelter and food, and of course also access to healthcare. Then we have a shelter with 22 boys who are staying with us, where we try to, of course, put them through the educational system and provide them with psychosocial care and legal advice, so they can find also their way. And finally, we have an educational center, our Horizon Center, in cooperation with MIT, where we provide what we believe is quite cutting-edge education for this group. Try to find also for them a future, to give them a future and a hope for them in Greece or wherever they choose to settle. So this is our work. Thank you.
Thank you, Kenneth. Thank you for introducing FARers to us. And now I'm going to move to Polybienestar at the University of Valencia.
So hello everyone, I'm Tamara Dambra. I work as a researcher at Polybienestar Research Institute, which is an institute, a public research institute belonging to the University of Valencia in Spain. Polybienestar is specialized in research, innovation, and social technology, and training in the field of public policies, especially on health and social innovation. So we have been working in European projects over 10 years now as leaders or as partners. And we work mainly in the field of social science and health science with vulnerable populations such as migrants and refugees. So that's our role.
Thank you, Tamara. Thank you, Tamara. Thank you for introducing the Polybienestar Institute to us. And now I'm going to move to the Cyprus International Institute for Environmental and Public Health at the Cyprus University of Technology. Sorry.
Hello, everyone. I'm very happy to be here. My name is Ekaterina Kyprianou, and I'm part of the Cyprus team. So a brief history about Cyprus International Institute for Environmental and Public Health. It was established in 2004 by international agreement between the government of Cyprus, Harvard School of Public Health, and Cyprus University of Technology. And since 2009, CII has been an element of Cyprus University of Technology's Faculty of Health Science. And the vision of the Institute is to train a new generation of scientists in Cyprus and the region in the fields of environmental health and public health. And specifically, it gives emphasis on the prevention of chronic diseases for the Cypriot population, including interventional studies to reduce health risks. Some of the research topics are smoking, obesity, diabetes, and etc. So the team is consisted of Dr. Kostas Christofil, which is the associate professor, me, and of course Eleni Ioannidou, which is a research assistant. So that is all from me. Thank you.
Thank you, Ekaterina. Thank you for this introduction. And now that you have a better view of who we are, I think it's important for us to, well, move a bit from the general topic, which we've been discussing, and move into the more specific. And since we've been working on this topic in our countries, we thought that perhaps it would be a good idea to give you a very short, broad partner country overview of the situation of migrant and refugee children in our countries. Now, as a way of introduction, I want to say again, well, Europe has of course experienced a lot of migrant and refugee influx in the past years, and this is true for all of Europe. But of course, not countries are equally affected, and so a more concrete country analysis should make the picture more clear. And we'll do so again by going through the 5 partner countries in the project, that is Germany, Spain, Greece, Italy, and Cyprus. Now, I will start with Germany. Well, like in previous years, Germany remained the top destination for refugee and migrant children, registering 37% of all child asylum applications between January and June of 2020. And in fact, the share of children in the total amount of first-time asylum applicants in Germany is 54%. That is data for 2020. And as you can see here, it's the greatest share in all of Europe. So we do receive a very large amount of migrant children, which is important because, again, it goes back to what we discussed before, it creates challenges for the health system in dealing with this particular demographic. Now, you have to understand this in the background that almost 1 in every 5 persons in Germany either is herself a migrant or comes from a first, second, or third generation migrant family. And in children and adolescents, this figure is even higher at around 30%. So you can see that this issue is very pressing here in Germany. Now, let's move and talk a bit about the health system. Now, in Germany, these children of asylum seekers are subject to the same legal status as the adults. That is, that during their first 15 months, they are only entitled to very basic healthcare services. And according to the law, and this is one big issue, this right to medical service is only there in the case of acute and acutely painful illnesses. So for instance, mental illnesses don't count. And this is a problem because as Professor Kumar has mentioned, very often these children are very much traumatized. They suffer from very often from many mental illnesses that they obtain during their trip to the destination countries. Now, these legal restrictions have, of course, been coupled with administrative barriers, but recently they have been reduced in some states in Germany because Germany is a federation, and some states have been able to give migrants vouchers or refugee cards so that it makes their access to healthcare easier. Now, after these 15 months of residence in Germany, the asylum seekers are then integrated into the mainstream system and are entitled to social benefits. However, for minors, they fall under the responsibility of the Youth Welfare Office. And this is actually a good thing because, well, the healthcare for these minors are based on the minor's individual needs, and no longer on very general restrictions, general legal restrictions. And it also means that then they have access to psychological care. But then it might be too late. And this is one of the issues that Germany suffers from with respect to providing healthcare for children. Now, we will come back to this later because we've done a lot of research on this topic, but we just wanted to give you a very short overview of the situation in Germany. And so I'm going to move now to Greece, where our Greek partners have been kind enough to prepare an overview of the situation in their countries to share with you the audience today.
Yes, my name is Bettina Wind. I am a partner, part of the organization Pharos, one of the partners of this project. Yeah, and I'll introduce you a little bit to the situation in Greece. So between January and November 2020 and 4,520 refugee and migrant children arrived in Greece. So these are the most recent numbers. And we can see that this is a decrease from the past years. And you can also see this from the graphic that has been supplied by the Greek National Center for Social Solidarity. They keep track of how many children are registered in Greece. And we see that there's been a constant decline for the past few years. But in total, the number of children living in Greece is 44,000. And about 4,000 of these are unaccompanied minors. In the camps, on the islands mostly, but also on the mainland. And what we call SILs, which is semi-independent living. So that's children or adolescents who are independent enough to live in separate apartments with less adult supervision. And then hotels and apartments. And then of course we have children that live in these what we in Greece call precarious living situations. So if you can see from the graphic that 644 children are right now waiting for placement in shelters or more permanent accommodations. And that means that they're living either apartments or on the streets. So this is the situation for unaccompanied minors in Greece mostly. When it comes to migrant children and who are accompanied by family members, they will mostly live in camps or in urban areas. They will live in apartment buildings or in apartments provided by NGOs. Yeah, and just to give you an idea of the demographic of refugee and migrant children in Greece. So 38% are from Afghanistan and 24% is from Syria. And so the main population is from these countries that are war-torn countries. And then we also see Democratic Republic of Congo and Pakistan, and also we've also experienced increase in refugee and migrant children from North African countries such as Egypt and Morocco. We've seen, yeah. So this is the demographic of children in Greece. So then I'll tell you a little bit about the health system in Greece for those of you who are not familiar with this. So the Greek healthcare system is provided through mainly privately contracted physicians and public hospitals. And you access this healthcare system through a social security number that we call AMCA. And everybody has been, up until January 2020, everybody has been provided an AMCA number upon arrival. So when they apply for asylum, they receive this number. Now from January 2020, a new system has been put into place, which is a temporary social security number. And the name of the, we call it PIPA. And this is the number that you hold as an asylum seeker. And of course, like I mentioned, the nature of this other kind of social security system is that it's temporary, because AMCA is permanent. Yeah. So upon achieving refugee status, so when a child goes from asylum seeker to recognized refugee or a residency card holder, they will acquire an AMCA number. So this is the permanent solution that they gain right to acquire this. And yeah, there's some challenges in that I can talk about a little bit later. Medical, yeah, so there are many gaps in the Greek healthcare system. And because some some people aren't registered here. Some want to go to Germany, like Louis also mentioned that, you know, that Greece is not usually a destination country, it's more of a transit country. So many people don't want to be registered as an asylum seeker, and that means that they also don't have access to healthcare, right? So a lot of these things are offered by NGOs such as Médecins Sans Frontières, Praxis, Solidarity Now, and the Red Cross. So they have different organizations that they provide these services for if they don't have AMCA or PAIPA. Yeah. So mental health care is also one of the huge kind of deficient areas of healthcare, could you say, that lack some or that have some deficiencies. There is a huge need for mental health care spaces, and but there are not a lot of beds, and especially in the rural areas of Greece. So if you can imagine the map of Greece, you'll see that many, of course, are islands or rural areas, and they don't have beds for mental health care patients at all. And yeah, social welfare is also provided through the municipality for the local governments, but again, highly relying on NGOs for psychosocial support and from funding from national bodies such as UNHCR and the EU. Yeah.
So thank you, Bettina, for this overview. Now we are going to move to Cyprus, where our colleagues from the Cyprus University of Technology are going to give us, well, again, an introductory overview of the situation there.
Okay, hello everyone. I'm Eleni Ioannidou. On behalf of Cyprus University of Technology, I will present the situation with refugee and migrant children in Cyprus. Between January and June 2020, 131 children arrived in Cyprus by the sea. Among them, 39 were unaccompanied. Most children originated from the Syrian Arab Republic and Somalia. And regarding, additionally, 63% of children who arrived in Cyprus between January and June 2020 were boys, and 37% were girls. Now, regarding the access of refugee and migrant children to health care and social services, we can go please to the next slide. Okay. From June 2019, a general health system, GESI, is in effect in Cyprus, introducing major differences in the provision of healthcare services. Recognized refugees and beneficiaries of subsidiary protection are eligible to receive healthcare in Cyprus under the new system, the GESI. Asylum seekers, along with the other parts of the migrant population, are not included in the provisions of GESI. So their access to health services continues under the provisions of the previous system, which basically entails treatment by public, inpatient and outpatient departments of the public hospitals. So since 2020, many difficulties in health provision in Cyprus were appeared due to the measures for tackling COVID-19. Also, I would like to mention that the Cyprus Refugee Council, offering a specialized social and psychological support to victims of torture and gender-based violence, operating through the funds of United Nations Voluntary Fund for the Victims of Torture and the European Union. This data is for Cyprus. Thank you.
Thank you, Eleni. Thank you for presenting the country situation of Cyprus. And now let's move to Italy, where Zadig is going to tell us a bit more about how migrant and refugee children are doing in Italy.
Thank you, Rui. So if you can change the slides, okay. So on 2020, total asylum application by minors exceeded 11,180. But in the first half of 2021, 5,526 refugee and migrant children arrived in Italy. That corresponds to 22.3 of total arrivals, so more or less a quarter. And they are composed by 1,213 accompanied minors and 4,313 unaccompanied minors. In absolute terms, this amount of arrivals is confirmed to be the highest among European arrival countries in Mediterranean area for the first arrival. And that represents a small decrease from the same period in 2020. But both years, 2020, 2021, shows a significantly higher trend than the previous year. In 2019, they were a third, 1,618 of unaccompanied minors. In Italy, the census number, or UASC, is only 7,802 and 96 males and 3 females. And we have 145 projects in the territory designed to specifically accommodate these minors, but for a total of only 4,369 units. And we don't know exactly where the other can be. It's estimated that 1 in 4 of them leaves the shelter center and the integration system shortly after arrival, probably trying to go for Germany or in different country. The next, please. So about the access to healthcare and social services. We have, of course, specific regulation, but the most important law is the so-called Zampa, from the name of the vice minister that proposed that law. And the law recognizes the special vulnerability of unaccompanied minors and guarantees, theoretically, that the same rights and protection enjoyed by minors from Italy and from other European countries. Unaccompanied minors must have access to the Italian National Health Service during their stay in Italy and must be admitted to the educational institutions. They also have the right to be informed about legal representation, which should be funded by the state. This is the theory. And the UNICEF project, strengthening the health status of refugees and migrant minors, supported by the European Union, highlights for Italy 4 specific issues of intervention on which improvement is needed at all levels, that are primary health care, mental health and psychosocial support, gender-based violence prevention and response, maternal and child health, that are also our main issues, specific issues of our project. Finally, the impact of the COVID-19 pandemic is not yet adequately quantifiable, but it's important to show that all solidarity programs for the reception of foreign minors have been suspended since June 2020. And the work of a large number of health workers has been redirected to cope with the emergency. So we can imagine that the conditions of the minors in Italy has worsened. Thank you.
Thank you, Eva. Thank you for this overview. And finally, let's move then to Spain, where Polly Bienestar will give us an overview of what migrant and refugee children are experiencing in that country.
Okay, thank you, Rui. I will present now some key data in regard to the situation of migrants and refugee children in Spain. So from the last report produced by the government, we have most of the foreign minors that are arriving to Spain are male, over than 90% compared to women. Of those unaccompanied minors, most of them come from countries such as Morocco, Algeria, and Guinea. And in 2019, a total of 509 children arrived to Spain by boat, accompanied by an adult, but this adult didn't provide an accreditation to support that they were family. So we don't know if they are actually accompanied or are unaccompanied minors. A total of 2,417 minors were registered in Spain in 2019 as unaccompanied minors, and they were placed under the guardianship or foster care protection services. And again, most of them were boys in comparison to girls. According to the latest data of the Office of Asylum and Refugee, a total of 98 unaccompanied minors applied for international protection in Spain. In comparison to, well, this is an increase in comparison to 2018. Most of these minors were Africans from Egypt, Guinea, Mali, or Morocco. And then the second continent is Asia, with most of them coming from Syria. According to the Committee of Rights of the Child in Spain, there were several structural difficulties and serious concerns about the situation of unaccompanied minors. Most of them were, for example, provided with an erroneous medical diagnosis and the wrong treatment. And there were also reports of isolation or overcrowding. Next slide, please. So we face several problems in regard to the access to healthcare and social services for this specific vulnerable population. In terms of access, there is a disparity in the health services, which can be related to a lack of familiarity among these populations. Also, communication barriers between professionals and the minors, and also differences in the perception of health and health behaviors. In regard to the chronic and infectious disease, there is also a certain vulnerability to some infections and problems related to this vulnerable population. And again, mental health is a key issue in this regard. And some factors that are related to mental health is there is a lack of understanding among professionals and professionals working in the field of the immigrant culture, and that can be also a serious barriers. And some recommendations to improve this access to healthcare and social services is to ensure the entitlement, support, equity, and reduce barriers among health professionals and within the healthcare provision. Also to design to tailor health programs specifically for that population, and to promote the use of healthcare services among this population, for example, using cultural mediators, promote awareness and detection of infectious disease and other problems related to the health of migrant populations. Also support the pro-employment and social protection policies aimed for those specific populations. And one of the most important issues that we have also addressed within a WebCare project is the access to mental health services. We need to provide this support to this population. So thank you.
Thank you, Tamara. Thank you for giving this very nice overview of the situation in Spain. And with that, I would like to close off this particular part. But before we go, I want to make a few information points. First of all, this symposium is being recorded and will be made available online. So all participants of the recordings will be able to see this event later on YouTube, and it will also be posted on the website. So you will receive an email with the link so that you may catch up on anything that you may have missed during the symposium. That includes, of course, the presentations. So please don't feel too worried. You will receive the presentations, or at least a video of the symposium. Second, we ask you that once the symposium ends, that you fill in an evaluation questionnaire. That's very important for us to improve the quality of our work and of our symposium. So I'm sending you now in the chat a link in which you can use to fill in the questionnaire. Finally, I want to thank you all for participating in this first part. The next part we will focus on the project EU VetCare itself, but now I'm going to we're going to have a break of about 15 minutes, and we will come back at 3:30 Central European time. Thank you, and see you in a while. So we still have 1 minute to come back from the break. And I just want to use this minute to do a few reminders to those of you who have missed it. So first of all attendants can get all participants can get a certificate of attendance. All that they have to do is send us an email. The email which you have to send, the email address to which you have to send an email is on the chat. That is my email address. Also, this event is being recorded, and the recording of this event will be made available online. So you don't need to worry. If you miss something, you'll be able to check all of the presentations and all of the talks that took place here today online later. And we ask that if you have any questions now, that you write it down, and then we can address them in the questions and discussion section of the symposium, which is going to happen at the end of the symposium. And finally, if you be so kind to fill in this evaluative questionnaire, it would be great, because it would help us improve our events and also our project. So I'm sending you again a link in the chat which you can click to and then fill in a questionnaire about the symposium at the end of the symposium. Now it's time, so I guess we will start with the second part of the symposium, and that's the part in which we talk a bit about our project. It would be appropriate to start with the first thing that we did at the beginning of the project, which is the background research that we did. We did a lot of background research, and we found many things, and we would like to share them with you today. And Dina Zotak, Dr. Dina Zotak from Prolepsis is going to be doing this presentation today. So Dina, the floor is yours.
Thank you very much, Rui, for the great organization, and thank you everyone that you are here with us today to learn more about our project. So I'm going to share my presentation. And in the next few minutes, I'm going to present the research findings of our project by starting from the research activities that we realized as part of the EU Care project, and then presenting the findings of the literature review, the mapping of training opportunities review, and the qualitative research. So our research activities were conducted in the first year of our project implementation, and this means during 2018 and 2019, and they include the literature review in the consortium countries and at the EU level, the mapping of training opportunities in the EU 28 member states, and our qualitative research, which means focus groups with the project target groups. I am starting with the literature review. And what we did was that we reviewed scientific articles using the Medline, the Scopus, and the IC Web of Knowledge databases. And we also searched for literature in websites and online resources of public health and non-governmental organizations, such as the WHO, CDC, International Organization for Migration, Institute of Medicine, etc. And we also reviewed other national organizations from our consortium countries, but also from other countries such as Denmark, Ireland, etc. The literature search was performed from 2010 onwards, and our relevant report was concluded in June 2019. So some of our main findings from the literature review, and as you see, there are some, let's say, common findings with the great presentation that we also had during our introductory session. And I'm starting from the frequently reported barriers by healthcare providers of migrant refugee children. And these are the frequent relocations of migrant and refugee children, which leads to limited continuity of information, The unknown medical history, due to the fact that there is usually absence of medical records. So health professionals have to be based on oral information from children's families, and this is a more important barrier when it comes to unaccompanied minors. The poor health literacy, which usually leads to inadequate and poor understanding of prescribed treatments, diagnostic interventions, and preventive interventions. The cultural differences, which has to do with inadequate knowledge base of health professionals regarding cultural dependent symptomatology or physical complaints. And we see that there is a lack of correspondence between the perceived health needs of the pediatricians and the children, and the limited access to or limited availability of professional interpreters and cultural mediators. Now, some of the most important issues in which health professionals have to be adequately trained on, based on our literature review, are immunizations, psychoeducational evaluation, developmental surveillance and screening at regular intervals, recognition of migrant refugee children, health barriers, traditional medication and therapeutic practices applied in the country of origin, the emotional, behavioral, mental and physical problems most frequently faced by migrant and refugee children, the prerequisites for a sufficient medical history, and the provision of culturally competent care, which means knowledge, attitude, and skill development in culturally and linguistically effective practices, as well as cross-cultural communication. I'm moving on with the mapping of training opportunities review that took place by the EU Vet Care Consortium. And as the consortium, we reviewed the existing training programs on the delivery of health and social care to migrant refugee children, including unaccompanied minors, that were available for physicians, nurses, psychologists, social workers, cultural mediators, and other aid workers. We tried to collect information from academic departments and institutions, from governmental sources and non-governmental organizations as well. And we tried to identify educational opportunities for the last 5 years, which means from 2013 until 2018. And we finalized this report in 2019. You can see here the number of educational opportunities that we managed to collect per country. And our consortium collected and reviewed 186 training programs in the 28 EU member states. And in Italy, Greece, and Germany, we found the largest, let's say, number of training programs, while in Cyprus, Malta, Portugal, and Latvia, we identified a very low number of training programs. We reviewed all the educational opportunities that we managed to collect, and we saw that they mainly focus on trauma and post-traumatic stress disorders, intercultural mediation and conflict resolution, mental health and psychological support. While we saw that the most important gaps and needs are regarding racism, discrimination and xenophobia, human trafficking, children with physical and mental disabilities, sexual orientation and gender identity, and age determination of migrant refugee children and unaccompanied minors. A major disadvantage that we identified was that little emphasis is given so far on training psychologists, while migrant minors and especially unaccompanied children may have multiple risk factors for potential mental health problems, including trauma, forced migration, and stressors associated with their settlement. Moving on to our qualitative research, our aim was to identify the main training gaps and perceived needs among professionals caring for migrant and refugee children in the 5 consortium countries, which is Germany, Cyprus, Italy, Spain, and Greece, and more specifically to gain a deeper understanding on the barriers and facilitators related to professional daily practice, on their own perceptions towards their training, and on their own needs towards training on migrant and refugee children care. So what we did was that we had 3 focus group discussions in each partner country with physicians and psychologists, social workers and cultural mediators, and representatives from migrant refugee organizations, children's protection organizations, vocational training providers, and policymakers. Each group's duration was 60 to 90 minutes, and we had 4 to 8 participants in each one. Of course, we faced some recruitment difficulties, and in some countries there were fewer participants, but we had a written informed consent and completely descriptive questionnaires at the beginning of our focus groups. The data were collected and analyzed between April and September 2019. You can see here that in total we had 99 participants in 15 different focus groups. The mean age of our participants were 40.8 years old, 73% of them were females, 82.8% completed at least tertiary education. Most participants were social workers, followed by psychologists, physicians, and cultural mediators, while 84.4% of them worked full-time on average for 7.5 years with migrants and 6 years with migrant children. So the most important findings from our focus groups were that health professionals face many problems in the provision of care to migrant and refugee children, with many reporting symptoms of occupational burnout. Most important problems and barriers reported by health professionals were the lack of medical and vaccination history, the lack of epidemiological data from the country of origin, bureaucracy issues, insufficient number of translators and cultural mediators, and lack of intercultural competence. Common training needs among physicians, psychologists, social workers, and cultural mediators were identified. Based on our focus group participants, the face-to-face training was preferable. They would prefer for this to be carried out by trainers with experience in the field. Emphasis would like to be given to experiential and practical methods such as role-playing, case studies, and best practices. The development of an e-learning platform was considered positive, while they would like to receive certification and accreditation of the training by official bodies. Based on these findings, the EU Vet Care training course was developed. The training that will be described later on comprises from 10 training modules, 5 interdisciplinary and 5 specialized, which are also available through our e-learning platform in all consortium languages, which is English, German, Greek, Italian, and Spanish. Thank you very much for your attention.
Tina, for your presentation. So now I hope that the participants in this symposium have a better idea of the needs that we found when we investigated the opportunities for training of healthcare professionals dealing with migrant and refugee children. You saw that there were some desiderata that were very prominent. So for instance, they wanted to have something which they could, which would be recognized, something which was accredited. They saw the development of an e-learning platform as something positive. Still, they wanted to have some practical aspect of the training there, so that they could get some practical guidance on how to deal with these issues, the issues that pop up in their daily practice. And of course, it would be ideal to have a training done in person. With that desiderata in mind, we went on and worked on certain modules, and we developed, as Ina said, 10 modules, 5 of which interdisciplinary modules, and 5 of which specialized modules for special professions. And now we will move into the part of our talk in which we actually introduce this module to you. We show you what we produced, and for that I'm going to be introducing you Eleni Ioannidou. Eleni works at the Cyprus University of Technology, and she'll be explaining to us what exactly it is that we did and why is it important. Eleni, the floor is yours.
Yes, hello again. I'm going to present educational modules that have been developed by the EU Vet Care partners based on the identified health and social professional needs, as well as the gaps in specialized training in this area. First, let's begin with the educational modules for the interdisciplinary part, which were 5 modules. Let's see one. Module 1 is about the legal framework and protocol for working with children. For each module, we will see today the module content and the learning outcomes for each one. In this module, trainees will learn about children's rights in Europe and worldwide, as well as laws and protocols concerning refugee children and unaccompanied minors. And also they will be presented with case studies and legal practices that are relevant when working with migrant and refugee children. Upon completion of this module, participants should be able to be aware of the rights of children under international and European laws, to find out the rights of children in healthcare at European and worldwide level, to understand the importance of the European laws and protocols for migrant and refugee children, to recognize laws and protocols under country-specific policies, to figure out the specific laws and protocols for unaccompanied minors, and inform other health professionals, about the rights of migrant and refugee children that have under some international and European laws. Let's go now to the module 2, which is interdisciplinary collaboration. In this module, the trainees will learn about the concept of integrated care to promote quality improvement amongst migrants and refugee children, to learn about the different theoretical models and practices for better coordinated care and greater patient experience, as well as cost efficiency and improved health outcomes. To know good practices of integrated care for children and guide for assessment of maturity healthcare systems for the implementation of integrated care, and to have the tools for the healthcare practitioners to access their maturity level to adapt the good practice into their system. And the learning outcomes for this module is to define different collaborative care models, to describe the benefits of each collaborative model, and to define an evaluation strategy. And finally, they will plan the adoption of an integrated care practice. Now about the module 3, which is cultural competence. In this module, the trainees will learn the patient-centered care model to gain better knowledge of different approaches for the empowerment of the migrant minors within healthcare settings, to learn how to address low health literacy among migrants, minors, and caregivers, to focus on the needs for reducing health inequalities and meeting the health needs of migrant minors and caregivers by becoming a culturally competent healthcare organization. And moreover, the module will focus on the cultural competence of professionals, providing information and competence about how to maximize the culturally sensitive response to the needs of migrant minors and their caregivers. Some of the learning outcomes for this module is to understand the principles of patient-centered care applied for migrant minors, to define and apply patient-centered care, to define what is health literacy and why it is important. Also to access the empowerment migrant minors health literacy. And in the second part of this module, trainees should have better understanding of the concept of cultural competence to gain greater consciousness of one's personal reactions to migrant minors and caregivers in practice, to critically evaluate their own beliefs and values about cultural differences, to put in practice skills to practice cultural competence, to make a cultural competency part of the institutional agenda, self-assess of the cultural competence of the organization, to identify and report disparities, and finally to develop culturally competent health programs and interventions and involve the community. The next module is about communication issues. The module 4. In this module, trainees will learn specific communicative skills and tools that can help to recognize the different needs of migrants and protect them while building an empowerment context. To start by learning about self-awareness, empathy, and active listening techniques, non-verbal and paraverbal languages as a conceptual scheme that meets the multicultural context of work with children. To learn about unconscious bias among healthcare and aid professionals that can contribute to health disparities and affects the communicative process. And also to learn about distinct models of childhood and parenthood and the prevailing methods to communicate with children. So the learning outcomes for this module is to be basic communicative tools to engage migrant children, to put into practice the main knowledge about the counseling approach, to identify different conceptions of body, care, childhood, and parenthood that can shape the communication and the relationship with the healthcare provider, and also to identify the different way their implicit bias could affect an effective healthcare. The last module for the first part is the module about burnout, stress prevention, and management. In this module, the trainees will learn about how stress and burnout develop and how they are connected, as well as be given an overview of individual and organizational stress factors and triggers and how they could cause long-term stress and burnout. Learn about different signals and symptoms of stress and burnout, to learn about the phenomenon vicarious trauma, its emergency risk and consequences, as well as about the occurrence of vicarious trauma in child and youth welfare services. And also to be given practical tools and methods for preventing such trauma and learn how to implement them in daily professional work and own institutions. Therefore, upon completion of this module, trainees should be able to recognize professional challenges that might trigger stress and burnout when dealing with refugee and migrant children, to recognize symptoms and signals of vicarious trauma, to implement preventive methods of stress and burnout in their daily work, and to enhance their self-care competence. Now that we have covered the interdisciplinary part, let's go to the specialized part, which is consisted of 5 modules. Let's see, the module 1 of this part is about how to work with interpreters and cultural mediators in the context of treatment and counseling. In this module, trainees will learn about interpretation and cultural mediation in intercultural care, the different forms only of interpretation and the use of professional interpreters, to learn a theoretical framework of engaging in triads of communication and how this affects different professional contexts. And finally, trainees are provided with a practical framework for planning and executing effective communication within provider, patient, and integrated triads. So the learning outcomes for this module is to create an effective interpreting framework in the triad, to be aware of certain roles and expectations in the triad, to successfully apply rules and to ensure smooth communication, and to identify conflict situations and intervene in time. The second module is about the services of interpreters, cultural mediators, cultural interpreters, that is a specialized module for cultural mediators. In these modules, trainees will learn the basics and theoretical background of the work as an interpreter, cultural mediator, or cultural interpreter, to learn how to deal with common conflict in situations and misunderstandings and provide practical solutions for them, as well as how to avoid common failures during the treatment counseling session. Also, to learn about the professional ethical principles and moral obligations of interpreting. And finally, they will be given an overview of the general competence in a profile that the professional interpreter, cultural mediator should have in order to give him or her a reference to compare own skills and fields of improvement. So upon completion of this module, trainees should be able to know the field of action, the possible applications, and the setting, to be aware of the special role of the interpreter and the triad interaction, to know the ethical principles of interpreting and reflect on their actions, to cope with tasks and possible conflicts during the interpreting session, and to improve their interpreting skills and techniques. The third module is specialized module for psychologists. It's about managing mental health. In this module, trainees will learn about the risk factors and protective factors influencing the unaccompanied minor's mental health, as well as different ways of screening for mental health issues and establish mental health interventions. Also, the learning outcomes for this module is to identify risks and challenges in mental health care for refugees and migrant minors, to recognize resilience factors and coping mechanisms in unaccompanied refugees and migrants, to understand the impact of trauma of the brain and how that relates to unaccompanied minors. Moreover, to understand the development of displaced children, to perform risk assessment for unaccompanied minors, and lastly, to point towards levels of interventions and treatments of psychiatric distress in an unaccompanied minor base. The fourth module is specialized module for social workers, about recognizing and managing trauma and PTSD. In this module, trainees will learn the definitions and main characteristics of trauma and post-traumatic syndrome, including the DSM criteria for the diagnosis of PTSD and the specific aspects of trauma and PTSD in children. To learn the magnitude of the phenomenon of trauma and PTSD in minor migrants, including the main risk factor and triggers, with special regard to pre-migration life journey and life in the country of arrival. Also, to learn the consequences of trauma on migrant children and adolescents, including how to recognize signs and symptoms of trauma and PTSD, how to assess long-term risk and how to prevent them, and also to be made aware of the role of social workers working in connection with minor migrants traumatized. They will learn how to adequately communicate, especially with unaccompanied minors, considering language barriers and cultural background differences. So social workers, after the completion of this module, will know and describe trauma and PTSD with characteristics in children, to think and take in account triggers and risk factors for stress and trauma, especially in minor migrants and unaccompanied minor migrants, to early recognize signs and symptoms of trauma or PTSD, and adequately listen and understand needs and different cultural approach to paint a brief and well communicate with minor migrants, especially unaccompanied minor migrants. Finally, to manage the first phases after hypothesis of trauma, PTSD in minor migrants. And the last module is specialized module for physicians, is how to address the health needs of migrant and refugee children. In this module, the physicians will learn more information about the factors influencing the health of migrant and refugee children, the cultural issues affecting the health of migrant and refugee children, some common diseases and conditions among migrant and refugee children, the initial medical screen needed for migrant and refugee children, given specific guidelines and international protocols for working with children, the age assessment for this group, having also the opportunity to learn specific implications for practice and legal implications, the supportive structures and protective factors for the health and health promotion of migrant and refugee children, and also about the health promotion issues for migrant and refugee children. Upon completion of this module, the physician should be able to know factors that influence the health of migrant and refugee children, to be familiarized with the cultural issues that affect them, to identify which diseases are more common, to understand what points not to miss when they conduct the initial screening, to know about the consent and legal implications in regard to the age assessment of the children, and to describe the protective factors to the health of migrant and refugee children. And last one, to implement important health promotion strategies for migrant and refugee children. I would like to mention also that for each of the above mentioned training module has been developed to include the following parts: a PowerPoint presentation including the main content of the module, a complementing Word document which serves as the module's manual, providing all the background information of each specific subject, a vignette which is developed for each module. Each vignette includes a case study relevant to the theme of the module and corresponding question. The purpose of the vignettes is to contextualize the knowledge and skills from the training, making it more practical and applicable to a professional context. Moreover, the vignettes have the potential to spark discussion between trainees, enabling them to bring forward own experiences and from their work. And also the assessment quizzes and questions in order to evaluate the general knowledge of the module. Thank you. This is the educational modules of our project.
Thank you, Eleni. Thank you for presenting in a very general manner all of the modules in our project. Now, something that Tina pointed out in her presentation was that the participants found the creation of an e-learning platform positive. And with that, we actually created an e-learning platform. And I would like to invite medical doctor Maria Rosa Valito from Zadig to give us an overview of this e-learning platform so that we know how and where we can find it and how we can learn more about how we can treat migrant and refugee children better and provide them with better healthcare. Maria, the floor is yours.
Thank you, Rui. Good afternoon, everyone. Thank you for attending our meeting. I am a part of the Zadig partner, and I will present the learning platform, which means the intellectual output 5. I have to find it. Just a moment, please. Okay. I lost it. Can you see the slide now?
Yes, we can.
Yes. Okay, sorry. Okay. I say that the e-learning platform is the intellectual output 5. Just a few slides to summarize where we were at the beginning of the project, when we met in Berlin and then in Cyprus. It seems a century ago, because then the pandemics stopped our meeting, but we succeeded anyway in completing all the tasks of our project. The intellectual output 5 had some prerequisites for the courses. They were the courses had been targeted to the 4 professional profiles that our colleague mentioned before. It has to be a 2-level course with no less than 5 interdisciplinary modules and not less than 5 specialized training modules. And it has to be in multi-language, with the main course offered in English and then translated in the language of partners. I would like to remind you that at the moment in the platform, the main English course is the course with the complete offer of material that Eleni has described before. I mean, which the full text manual and the presentation plus the vignette and the question for the course, while the other 4 courses include just the presentation and the vignette plus some question for the participant to reach the accreditation. The prerequisites of the platform were user friendship, easy or open access, the ability to reach the largest audience, and the possibility of tracking users' activity and saving a learning session, also to comply with the accreditation rule. And the availability of assessment tool, both for acquired knowledge and user satisfaction. The selection of the platform was based on the previous activity we have developed during a European project, the Tell Me project, which was focused on transparent communication in epidemics, which is a topic that has come back to the forefront in the recent months. Anyway, during that project, we conducted a review of the literature and internet search to compare the offer of learning management system, which means platform for e-learning offered on the market. We considered exclusively open source technologies, and we have selected main criteria and secondary criteria for our choice. The main criteria were usability, adoption, language, and scalability. And we conducted a 2-round assessment, and considering 35 platforms, among them 5 were selected after the first round, and then just 1 reached the score to be considered the best after the analysis. The platform is a platform based on a Moodle system. Moodle is a learning management system or a virtual learning environment. It as promoted by the University of Technology, is a project designed to support a social framework of education and widely adopted in the world, even for small project of teaching or very large project of teaching, and is being adopted by university, school, institution. So it's widely used. At the moment, the last version available is the version 3.11. For our project, we used the 3.9, which was the one available approximately a year ago when we implemented the platform for UVET. And few figures at the moment in the world, more than 188 currently active sites are active, and these sites are present in 246 countries, including the 27 European countries. The platform provides 95 languages. Few words about the educational model we adopted that meets the needs that you have already listened to in the previous presentation. First of all, we can be sure from data in literature that the learning is useful and effective, as it can enhance knowledge, competence, and modify behaviors, and its effectiveness is comparable to that of traditional residential courses, and more effective than non-intervention. The majority of data are related to physician professional learning, but it can be easily extended to the professional profiles of our project. So it has been shown that physician performance and patient health is greater when the learning is interactive, uses multiple methods, as is focused on outcomes that are considered important by physicians. We can substitute the physician with the for professional profile of UVET project and patients with the recipients of care and support, I mean migrant and refugee children, and the conclusion may be the same. Moreover, learning addresses some of the critical issues of residential, in particular the problems of time and space, by making information available at any time and in any place to any professional. We all have learned in pandemics how much is relevant have a tool for remote learning at any level of learning activity, from school to academic activity. Just to summarize the comparison among the three main way of learning: face-to-face, learning on the field, e-learning. The difference in terms of participant, of interaction, on advantages and disadvantages of each way of these three ways. As already said, the learning offer a possibility to learn at any times and any place. Moreover, it offer homogeneous content. Obviously, the direct contact with teacher or tutors is missing, but the relevance of this aspect depends also on the topics we are addressing. According to me, for the UVET project, this disadvantage is quite limited. And another aspect that we considered, and it has been we have seen also from the analysis of the need that Prolepsis has presented after the first output of the project, the necessity to offer a learning program which was based on was able to respond to practice and centered on the professional need of the participant to the courses. The andragogical approach meets this need because thanks to the problem-solving approach. The theory of the andragogical approach is not new, because it was introduced in the 50s and it has been developed during the years. You can find here some source to be go in depth with this approach, because the time now at the moment for this presentation is few. We know. And another table to present a comparison between the pedagogic approach and andragogic approach, when the learner has to be autonomous and responsible for his activity, where the previous experience is crucial for learning, and the willingness to learn results from the professional role and the social role of the participant, which is well reflected by the 4 professional role we address our course. The orientation towards learning is centered on problem solving. The motivation is self-esteem and personal satisfaction, and need to learn descends from what it is useful in the real world. A tool we have adopted in our project is the Vignect. I hope to have time to present at least the first step of the Vignect. The Vignect is a complete story. It's not a clinical case. It's a story of a relationship, the story of involvement, of psychological involvement or personal involvement that present the professional and recipients of his or her care and support that interact together. And during this story, the user has the opportunity to know by identification with the professional represented in a story, and to learn from the story how to solve the problem presented in the Vignette. The Vignette is useful as it stimulates problem solving, meets actual training needs, reproposes everyday operational reality, allows for identification, as I have said, and hopefully may be interesting or even entertaining. The UVAT platform, this is the landing page. This is the website where you can go and find the courses. It now completed and available. It includes these files, which is the 5 courses interdisciplinary and the 5 specialized courses. The learning activities are to be completed by August the 21st, but while materials will be available for 2 years. This is our group. If I have some more minutes, I would like to present the beginning of a vignette. We have, can I have some more few minutes? Okay. I will present the vignette, the first one of the vignette. This is the vignette of the module specialized number 4, which is related to trauma and PTSD. The author is Valeria Confalonieri. I would like to thank her for his support to the production of all the vignette, because she was very precious in the development of the 10 vignette of the course. You will see in these few slides that the vignette is composed of various steps, and each steps include a story, a question, and a comment about why about the question, why an answer is right and the other are not. The story is the story of Giovanna, who is a cultural mediator, leaves the house with many thoughts and a lot of enthusiasm. She walks with long but low steps toward the place of her new job, a job she had dreaming of for a long time. Only a week ago, she received the phone call she had been hoping for. The job was hers, a collaboration for 1 year to begin with, of a day center of an NGO for migrant minors, where she would teach Italians the language of the country where they had arrived and were trying to rebuild their lives. She still remembers the excitement of when she had gone to the last interview at the NGO headquarters, the one that was decisive for their position. She remembers all the questions she had been asked, whether she knew the kind of student she would have, the possible problems she would encounter. Do you know the meaning of the word stress? Do you know what it can entail? Do you know what it will mean to have in front of you children who have experienced in the few years of their lives terrible and traumatic moments? This is the first step of story. This is the question with a list of possible answer. The user has to choose among the answer. After his or her choice, he goes to a page with present a part of the modules of the manual, and when he can find the why an answer is right and the other are not. The story goes on, but I think that I have finished my time.
Yes.
Okay.
So thank you, Maria Rosa. Thank you for giving us this overview of the e-learning platform. The participants will have the chance to visit the e-learning platforms themselves. The link is already in the chat. But now I want to move on to another topic, which is very often when training package is developed, not a lot of thought, well, a lot of thought is put into the training package, but not a lot of thought is put into the trainers. And in this project, we wanted to also think a bit about the trainers, and to that purpose, we developed a training guidance for them. And the idea is to help them develop the trainings and conduct the trainings in a more successful way. Kenneth Hansen from Faros is going to say a few words about this guidance that we developed. So please, Kenneth, the floor is yours.
Thank you very much, Rui. We don't have so much time, and I think it's also important to leave time for questions so our participant can make any questions that they might want. So I will go through it a little bit quickly, but yes, indeed, I have good news for all of you who have participated in this symposium, and maybe you think there was an overwhelming amount of information. We have done it a little bit easier for you, and we have produced this guidance note that I will just shortly present now. I hope this, the aim of this is to give you an overview of the whole project from the conclusions of the research that also Dina presented earlier, the modules of the training that Eleni presented, and also, of course, the e-learning platform, and also our pointers and recommendations to the trainers that would like to implement this in their own organizations. So yes, it is to provide an overview and the guidance to give EU vet trainers concrete guidelines and recommendations for conducting training and transfer the knowledge obtained in the project in your respective organizations. So we're just, it's a little bit of recap we are doing here for what we have been doing the last hour. In the beginning of the guidance note, which will be approximately 20 pages long in each language, and of course we'll produce it in all the languages represented here in the partnership. So we start in the first part just to give you an overview of the research that was conducted and what the research, the desk study and the focus groups, what kind of needs they revealed for the training that we then later conducted. So some of the conclusions of the research was that we needed more information about the legal framework, both the international, the European, but also our national frameworks for children in healthcare, child-specific protocols, interdisciplinary collaboration, a by proxy approach to interpretation, how we do intercultural education, communication skills for interacting with children. Child psychology in general was something that we didn't find there was a gap in training generally. Integration initiatives for tackling alcohol and drug abuse that we also see, unfortunately, is quite common among the target group. Burnout, stress management, and also how to work with cultural mediation and translators. So based on these conclusions of the research, as you have seen previously, we developed these two parts, an interdisciplinary part and the specialized part with 5 modules in each part. And in the guidance note, you will very easily, on approximately half a page, get an overview of each module to see the training, the objectives of the module, what it is you will learn, the learning objectives, and so on. A short description of the content, so you can easily judge: is this also relevant for me, for my organization? Is it a training that I would like to do? So just to recap a little bit, we have the 5 modules for the interdisciplinary part: the legal framework and protocol for working with children, interdisciplinary collaboration, cultural competence, communication issues, and the final one, burnout and stress prevention and management. And the specialized part, also the 5 modules that Eleni presented earlier, working with interpreters and cultural mediators, services of interpreters and cultural mediators, which were targeted directly to this group, managing health, mental health for children, which was a very sought out topic, recognizing and managing trauma and PTSD, and module 5, addressing the health needs of migrant and refugee children. So we did the training approximately 1 month ago, and from the feedback that we received from the trainees, it was quite a successful training, but of course there's always things you can learn from and things that you can improve. So what I just want to spend the last 2 minutes on is just to give to transfer some of the knowledge that we gained from doing these trainings to you. So perhaps you will you can take that into consideration when and if you set up a training within your own organization. So one of the things that we we identify this, that it is important, of course, that the trainers, instructors are well aware of the topic and they are professionals experienced in this topic. That each trainer and instructor should have long experience in that, and if they don't, then it has to, of course, be declared from the beginning if you are not a specialist in this thing, and then still there can be a good training and a good dialogue established, but of course it has to be kind of flagged from the beginning. We recommend up to 20 participants to facilitate interactions, and this is whether it is face-to-face training or if it is online. It's still, in some of the trainings we had up to 80 participants, and of course this hinders a little bit of free dialogue and person maybe hesitating to ask questions, and it becomes more a lecture than a dialogue. Of course, also working with professionals, it is really important to consider their availability, because most of them will be working full-time and maybe more than full-time. So really it's important to assess when is the right timing of this, morning, the noon, after work hours, when is it is more suitable to do a training like that. The vignette and the case stories that we presented, it's really important that you use them actively, because they do increase interaction and kind of you check that the knowledge has been transferred the way you want to do. And of course, this training material needs to be modified constantly, both because things they get out of date, but also because you might have to target it to your home country, the needs that you know is existing there. For example, the legal framework, it would be important to add some slides that are relevant to your country and the challenges there. Again, we consider always in-person training would probably be more preferable, but as also presented by Maria Rosa, that of course you can reach many more people by doing it online. But of course, the face-to-face, being in the same room, having a dialogue, having a discussion, is usually maybe a better way to transfer for the knowledge. Of course, to reach more people, online is still definitely a good alternative as well. I have already talked about the vignettes, the case studies. I think we'll go to the tips and lessons. All of these are, of course, also in the guidance notes, so you can read all these recommendations and tips there. Just go maybe some more of them. Again, use examples, use case studies, find your own examples if you can, make it relevant to the context that you're working in. This is always, of course, we all know that. We have all both been trainers and trainees, so we know that this is always works much better. We had the feedback that they would, some participants would have liked longer sessions that we had. We usually had 1.5 hour sessions, and of course sometimes a lot of material to cover in a very short time. So take also that into consideration. I don't think I will talk more with that. So I will stop my presentation here, so we have a little bit time for questions. So Rui, I give you back the floor. Thank you.
Thank you, Kenneth. Thank you for giving you this brief teaser of the guidance document that we prepared. And now it's time to go into the more interactive part of the symposium. We've discussed the issues that migrant and refugee children faced with respect to their healthcare. We discussed our project, how our project helps to solve these issues. And now I would like to open up the floor for discussions. If you would want to contribute with a question, a comment, or a curiosity, you can simply raise your hands. I have already a few questions here that was sent before. I think we can begin with the questions that were sent before. So first, Mrs. Uta Rübke, she asks, well, when we mean lack of cultural mediators, what do we mean? Do we mean the lack of financing cultural mediators, the lack of existing cultural mediators? or perhaps that there aren't enough well-trained mediators. And this question is something that we can actually ask, and I'll be glad to ask it to answer, because we work here at the Ethnomedical Center with many cultural mediators, and I would say it's actually very interconnected, right? Because, well, if you do not provide a lot of finance to the profession of cultural mediation, it's very hard to attract talent to well, conduct this profession. And so it's not as simple, oh, we are not paying them enough, or we are not, or there aren't enough interested people. It's actually both. There aren't enough interested people, also because we are not paying them enough. So I would say the issue is interconnected. And of course, the point that you mentioned, aren't there enough well-trained mediators? And of course, the answer is, of course, no. And the reason is that it's a very loose kind of profession. It's not centralized. There is no overarching register or central authority for this profession. And what it means is that very often these professionals have are only very loosely agglutinated. And this, of course, brings issue into the advancement of the profession, and which means that there are less professionals available. They are not well trained, and as you can see, things are very much linked. So that was one answer. Another question was put to us by Sarah Miller, and then she has a question. According to the pandemic, how would you execute the needs of your participants regarding face-to-face talks, role play, and case studies for the training? Are there any technical gadgets or platforms to better implement the practical training and the interaction within the participants and the trainers? And here I would ask members of the panel to chip in.
Okay, Rui, so perhaps I could start by saying that when we collected these research findings was back in 2018, 2019. So the pandemic wasn't actually into our plans. And our plans was that the training event that we held online would be a face-to-face event that would be held in Greece. So the plan was to have as many face-to-face activities as possible. Of course, then the pandemic came and this was no longer, and we didn't have the opportunity to do this. So we had to transfer the event online. Internally, what we did as a consortium is that we tried to include as many activities as it would be possible. For example, we had the case studies through our vignette, and into our sessions, we tried to make a discussion with the participants by asking them to answer. And we also used the chat where they would select the correct answer, etc. Of course, it wasn't a real discussion as we have imagined that it would take place if we were all together in the same room. Other things that we could use, for example, through the webinar would be to have some polls or other instruments that, for example, the Zoom platform gives us the possibility to use. But we show, as Kenneth presented from our questionnaires, the evaluation questionnaires, that participants would actually need more discussions and more activities. And this is something that we have as a lesson learned, for future, let's say, implementation of the training.
Can I add something?
Yes, please.
Regarding the requests of role playing, the vignette, luckily, is something very close to role playing, not active role playing, because obviously the participants are not active playing, but it's something very close, that we included before the pandemics, Dina said, because we use this model in our current activity, but also because it is a model of proven efficacy. So even the pandemics has stopped a part of our proposal, at least a part was already close to this kind of need.
Thank you, Maria Rosa. If you're fine with that, then now I'm going to move to the hands that are raised. So first, I'm going to ask Ilse Edanella. I hope I'm pronouncing your name correctly. Would you be willing to share with us the question that you have, if you still have that question? You can unmute yourself if you wish.
Ilsa, do you have received a message in which you can open your microphone?
Okay, so it seems that she is absent. So I suppose we pass on. I will pass on then the floor to Yasa Nasa. You may ask your question if you wish.
Okay, microphone on. Hello, how do you read me?
Yes, we do.
Yes.
Okay, that's very good. Thank you very much for the marvelous presentation. Actually, I was really amazed. I was asking myself and wondering, because I had the good chance to meet with many of the migrants and to ask them how you came to Germany or to Europe, and then the answer was really amazing for me. They told me that through their kids. First of all, they send their kids to Germany or to Europe, and according to the European law, then the kids have to live with their parents. It means they are facing their kids to a dangerous trip full with many horrible things. At the end, they are psychologically not in a good mood. And the father and the mother, the parents, they will come to Germany or to Europe by aeroplane in illegal transferring. How could you do, or how would will be your next step during this action? So for example, this is a gap of the law. I know that there are three options. First, they can be adopted by a family. Second, they can be returned home. But the third option, the parents can come here. I'd like to have an answer. Thank you very much.
Just one clarification to this question. Do you mean with respect to the amount and quality of healthcare that the kids obtain while they're in Europe, but without their parents?
Exactly.
Yeah. Yes. Yes. So this is actually a very good question, but it's also one very complex, because again, it's something that Eleni pointed out in her presentation. The legal framework for migrant and refugee children in Europe is not unified. We have very different ways in which reception countries deal with children, and this is also part of the reason why we had the first part of this country situation part. And the idea was just to show you that it really depends on where and when the children arrive. So I would say to give a very general answer would be hard, but I'll give the floor to my colleagues so that they may be able to say something more specific about this case.
Maybe if I must add, Rui, I have a background as a lawyer, so I have worked in many cases also with this, and it is a difficult issue. The way we see it is that in international law, and also which is implemented in European law, is that we have to look at the best interest of the child. This is the starting point. before we ever consider anything else, what is the best interest of the child? Is it to be returned to its parents? Is it to be reunified with, for example, family members in, now I'm from Greece, so we are from Greece, so many times they have family members in Northern Europe, in Germany, or in Sweden, or UK. So maybe the best interest is for them to be unified with their family members and then continue their life from there. But it is really difficult. But having this as a starting point, I think this is a good principle to always look at what is best for the individual. What can we do to help him or her to get the best possible life and future? And then the legal framework has to follow along. But Rui says, unfortunately, there are different, still, even if we are in the European Union, there are still different rules and different protection of this particular group. I don't know if this satisfied your question, but I think this is the closest we can get.
No, thank you very much.
We have now a question written in the chat that is from Fateme Hosseini. The person says that, well, given that most of the immigrants that were aimed in this project, what percentage of those you trained are people who have linguistic and cultural similarities with refugees? And also he says, many thanks for this nice and productive event. This is a good question, but we do not have, at least to my knowledge, a statistic with respect to the migration and cultural background of the people that we trained. I would say from our part, we do have a substantial percentage of people with migrant background who work in these areas, but it's not something I can say for certain, because we have no statistics. So if any other partner would want to add to that.
Really, that's true. Actually, we have some information about the country of participant to the training event, but not actually regarding their possible migrant background.
Yes. Because of that, it is the kind of information that we will really have issues providing. So again, if you have other questions, you can easily type them in the chat, or you can raise your hands, and then you'll be able to speak. Feel free to ask any questions that you have, even if you think it's a silly one, or if you just have a comment, or if you have a curiosity. We will be glad to interact with you. And in the meantime, I just want to say, if after the event, please, you can go online and well, visit the platform. I'm going to send the link in the chat now. You can visit the platform by yourselves. You can check what it looks like. You can check the content. You can register and make use of it yourself. And you can see the work that we've been doing in this past 3 years. So we have now a question from Justin. Oh wait, was that a mistake? I'm not sure now. Okay, someone raised the hand and quickly put it down again. So yes, please go to our website, see our platform. We are sure that if you work in this area, and if you want to have more background and training to working with migrant and refugee children, you find a lot of useful information there, and also useful material to do so. Now, Fateme asks again whether our project will be extended. Unfortunately, it won't. This is a fixed-term project. It was funded by the Erasmus program of the European Union. And it's supposed to last only for 3 years, and it's running out in August. We are we are sorry about that. But the e-learning platform is going to remain online for 2 years after the end of the project. So you still be able to make use of the outcomes of our project. Well, if no one else has any other question, then I guess we can slowly move towards the end of this symposium. We're already almost out of time anyway, and I would like to pass the words. The floor to wait. Before I do that, I just want to say thank you to the project partners. Thank you to all of you. Thank you also to the European Union for funding this project. Thank you to the NABEP for providing administrative support to the project. And thank you for the team here at the ENZ. Without you, the project would not have been possible. But anyway, I just want to pass the floor to our executive director, Ramazan Salman. Would you please say the final, the closing words?
Yes, thank you. I would like to take this opportunity to say a few thank you words. First of all, I would like to thank the external speakers, Professor Hayos Zeb and Benedict Kumar. Thank you for your insightful and excellent input to the symposium. Thank you so much. Second, this symposium would not have been possible without the dedication of the project partners. So thank you, Prolepsis, Pharos, Zadig, Polybienestar, and Cyprus University of Technology. It would also not have been possible without the financial and administrative support from the European Union and the NABEP. We are very grateful for their support. We are also very grateful to the team of the EMZ, who has been crucial to the success of the project, especially Ahmed Kimi, Daria Ryshova, and you, Rui. Finally, I would like to thank you participants for your time and interest in the symposium. We hope that you will be inspired and engaged by what we discussed today, and that you will strive to transform the healthcare for migrants and refugee children for the better. Thank you so much. Good evening. Thank you. Thank you.
Oh, before we all go, I just want to make a quick request. Can we have a group photo of the event? So if the panelists would like to open their camera so that we just see you and have a photograph, that would be nice. Thank you.
Where I can't find it.
I'm going to take the photograph now, so smile. Yes, thank you very much. That was it. And again, thank you all for participating. And yes, have a nice evening, afternoon, or morning, wherever you are. And we'll see each other around.
Good afternoon to everyone. Thank you.
Bye. Thank you.
Bye. Thank you.
Bye.
Thank you very much.
Bye-bye.
Bye.